The morning sun peeked through the blinds of Metropolitan General Hospital's conference room as the surgical team gathered for their daily meeting. Dr. Richard Harrison sat at the head of the table, leaning back in his chair with the casual confidence of someone who knew his worth and made sure everyone else did too. At 55, he was in his prime as head of cardiothoracic surgery, with salt and pepper hair that added to his distinguished appearance and a reputation that preceded him wherever he went. "The Torres case went exactly as I predicted," he announced, scrolling through his phone as he spoke. "Textbook procedure. 7 hours, not a single complication." He didn't look up to see if anyone was impressed. He didn't need to. After 25 years at Metropolitan and over 3,000 successful surgeries, Harrison expected admiration as his due. The other surgeons nodded, some genuinely impressed, others just going through the motions. They'd all heard Harrison's self-congratulatory speeches before. The man was brilliant, nobody denied that, but his ego had grown alongside his list of achievements until it filled any room he entered. Near the other end of the table sat Dr. May Lin, her dark hair pulled back in a practical ponytail, her hands wrapped around a coffee cup that had long gone cold. As the newest attending physician in the department, just 3 months out of her fellowship, she still felt like an outsider. She'd graduated top of her class at Johns Hopkins, completed her residency at Mayo Clinic, and earned stellar recommendations from every mentor she'd worked under. But here in Harrison's kingdom, those accomplishments might as well have been written on tissue paper. "And now," Harrison continued, finally looking up, "we have a new valve replacement scheduled for tomorrow. Mr. Reynolds, 67, history of heart disease." He glanced around the room, his gaze landing on May. "Dr. Lin, since you're so fresh from your textbooks, perhaps you'd like to outline the standard approach?" There it was, the familiar hint of mockery in his voice. Several of the other doctors shifted uncomfortably in their seats, but nobody intervened. Harrison's treatment of the new doctor had become an uncomfortable norm. May straightened in her chair. "For a patient with Mr. Reynolds's profile, I'd recommend a minimally invasive procedure through the right chest. Recent studies have shown faster recovery times and fewer complications, especially for patients over 65. Harrison's smile didn't reach his eyes. "Recent studies? How interesting. And how many of these procedures have you performed, Dr. Lin?" 17 during my fellowship, Dr. Harrison," she replied, keeping her voice steady. 17. He repeated the number as if it were a joke. "I've done 342. But please continue telling us what you've read in journals." A flush crept up May's neck, but she maintained eye contact. This was the game they played every morning. Harrison finding ways to remind her of her place in the hierarchy, and May refusing to be cowed. "I wasn't suggesting my experience matches yours, Dr. Harrison," she said carefully. "Just sharing current research findings that might benefit the patient." Harrison waved a dismissive hand. "When you've been in this field as long as I have, you'll learn that so-called current research often leads to dead ends. We'll proceed with the standard open approach. I'll lead. Dr. Peterson will assist." He nodded toward a middle-aged doctor who had been with the department for nearly a decade. "Dr. Lin, you're welcome to observe from the gallery, not even allowed in the operating room." The message was clear. She was still considered a student, not a colleague after the meeting broke up. May gathered her notes and headed for the door, but a hand on her shoulder stopped her. "Don't take it personally," said Dr. Anita Kapoor, one of the senior surgeons. In her late 40s, Anita had navigated the male-dominated world of cardiac surgery for over 15 years. "Harrison does this to every new doctor. It's his way of testing people. Seems more like bullying than testing," May replied, then immediately regretted her candor. Anita smiled, surprising her. "You're not wrong, but he's brilliant, and his patients have some of the best outcomes in the country. The hospital board treats him like royalty, so everyone just puts up with it?" "For now," Anita shrugged. "Look, I watched your work during that emergency bypass last week. You've got good hands and better instincts. Harrison sees it too, whether he admits it or not. He has a funny way of showing it. His approval isn't easy to earn, but it means something in this field. Just keep doing good work." Anita checked her watch. "I've got rounds. Hang in there, Lynn." May nodded her thanks and headed toward the cardiology ward for her own rounds. As she walked, she thought about her path to this moment. Medicine had never been her parents' dream for her. They'd hoped she would join her father's accounting firm. But from the moment she'd first seen a beating heart during a high school field trip, she'd been captivated, the perfect powerful muscle that never rested, never quit. She'd worked through sleepless nights in medical school, survived the grueling years of residency, and pushed through the intense specialization of her fellowship, all to reach this point. And now, the final hurdle was a man who seemed determined to make her feel 2 feet tall. She entered the room of her first patient, an elderly woman recovering from a pacemaker insertion. "Good morning, Mrs. Wilson. How are you feeling today?" The white-haired woman smiled. "Much better, dear. That young nurse said my numbers are looking good." May checked the chart and nodded. "Your heart rate is perfect. The pacemaker is doing exactly what it should." "Unlike my husband," Mrs. Wilson joked. 46 years of marriage and he still can't remember to put the milk back in the fridge." May laughed, feeling some of the tension from the morning meeting ease away. This was why she'd become a doctor. These moments with patients, the small victories, the human connections. As she continued her rounds, her phone buzzed with a text from the chief resident. "Harrison wants full workup on Reynolds before surgery tomorrow. Says rookie should at least handle paperwork correctly." The message stung, but May took a deep breath. Fine. If Harrison wanted a workup, she'd give him the most thorough pre-surgical assessment he'd ever seen. She spent her lunch break in the medical library, reviewing the most recent literature on valve replacements for patients with profiles similar to Mr. Reynolds. She pulled his complete medical history, noting details that others might miss. A childhood rheumatic fever, a slight irregularity in his blood work from 6 months ago, his family history of unusual reactions to anesthesia. By late afternoon, she'd compiled a comprehensive report that not only covered all the standard bases, but included several observations that might affect surgical decisions. She placed it on Harrison's desk with a sticky note. "Complete workup as requested. Dr. Lin." She was turning to leave when Harrison walked in. "Finished already?" he asked, picking up the file with an expression that suggested he expected disappointment. "Yes, sir. I've included notes on Mr. Reynolds' childhood rheumatic fever, which wasn't highlighted in his transfer paperwork but could impact valve selection." Harrison raised an eyebrow and flipped through the pages. For a moment, something that might have been approval flickered across his face, but it vanished so quickly, May wondered if she'd imagined it. "Well, at least you're thorough," he said finally, "though I could have done without the literature review section. This isn't a term paper, Dr. Lin. The recent studies on tissue versus mechanical valves for patients in Mr. Reynolds' age group showed some interesting outcomes," May said, refusing to be deterred. "I thought they might be relevant to your decision-making." Harrison sighed heavily as if explaining something to a particularly slow child. "What you fail to understand is that surgery isn't performed in research papers. It's performed in operating rooms on real patients where experience, not theory, determines success. With respect, Dr. Harrison, even the most experienced surgeons continue to learn from new research. That's how medicine advances." The room went silent. Several nurses at the nearby station froze, clearly expecting an explosion. Harrison stared at May, his blue eyes cold. "When you've held a human heart in your hands as many times as I have," he said quietly, "then you can lecture me about how medicine advances. Until then, remember that in this department, you're still the rookie. I didn't hire you for your opinions." With that, he turned and walked away, leaving May standing alone in his office, the sting of his words hanging in the air. Later that evening, as May was preparing to leave for the day, she stopped by Mr. Reynolds' room. The elderly man was sitting up in bed, his wife dozing in the chair beside him. "Dr. Lin," he greeted her with a warm smile. "Come to check on me before the big day?" "Just wanted to see how you're feeling," she said, checking his vitals on the monitor. "Nervous," he admitted. "But my granddaughter's getting married next month and I promised I'd dance with her. So I need to get through this." May smiled. "That's a wonderful goal to focus on. And Dr. Harrison is one of the best." "And what about you?" Mr. Reynolds asked. "The nurse told me you're new here, but very good." "I'm still learning," May said diplomatically. "Aren't we all?" The older man replied with a wink. "My wife says I still don't know how to load a dishwasher properly after 40 years. May laughed softly. "Careful not to wake Mrs. Reynolds. Well, cardiac surgery might be easier than domestic negotiations, as I see." He left the room, She nearly collided with Harrison, who was reviewing charts at the nurse's station. "Building rapport with my patient, Dr. Lin?" he asked, not looking up from his tablet. "Just checking his latest vitals," she replied. "His pressure's a bit elevated. Pre-surgical anxiety. Normal and expected." Harrison finally glanced at her. "You should go home. Tomorrow will be a long day, even if you're just observing." There was that dismissive tone again. May nodded stiffly. "Good night, Dr. Harrison." As she walked toward the elevator, she heard footsteps behind her and turned to find Dr. Peterson, who would be assisting in tomorrow's surgery. "Lynn," he called. "Hold up." She waited as he caught up to her. "What's up?" "Look, I know Harrison's tough on you," Peterson said, lowering his voice. "But I read your workup on Reynolds, catching that childhood rheumatic fever history. That was good work." "Thanks," she said, surprised by the unexpected praise. "Harrison noticed too, whether he'll admit it or not." Peterson pressed the elevator button. "Just keep doing what you're doing. Eventually, even the great Dr. Harrison will have to acknowledge good medicine when he sees it." As May drove home that night, she thought about Peterson's words. She hadn't come this far to be driven away by one arrogant surgeon, no matter how brilliant he might be. Tomorrow she would be in that observation gallery, watching every move Harrison made, learning from both his skill and his flaws. And someday, she promised herself, he would see her as an equal. Not because she demanded it, but because she would earn it. Patient by patient, surgery by surgery, day by day. In medicine, as in life, actions spoke louder than words. And May Lin intended to let her work do the talking. The operating room hummed with quiet efficiency as nurses and technicians prepared for Mr. Reynolds' valve replacement surgery. The overhead lights cast everything in a harsh, clinical glow, reflecting off metal instruments arranged in perfect order on nearby trays. May stood at the sink, methodically scrubbing her hands and arms, her mind running through the procedure ahead. Though she'd only be observing from inside the OR rather than participating, she had prepared as if she were leading the surgery herself. It was a habit formed during her training. Always be ready, always know more than you need to. The door swung open, and Dr. Harrison entered, already gowned and masked. He glanced at May with mild surprise. "I thought you'd be in the gallery," he said, turning on the tap beside her. "Dr. Peterson mentioned they were short-staffed today," she replied, keeping her tone neutral. "He suggested I observe from inside instead. I might be useful if needed." Harrison made a non-committal sound as he began his own scrubbing routine. "Just stay out of the way. This isn't a teaching session." "Of course," May said, maintaining her professional demeanor despite the slight. 15 minutes later, Mr. Reynolds was prepped and draped, his chest exposed beneath the bright surgical lights. The anesthesiologist nodded to indicate they were ready to begin. Harrison took his position at the table with Peterson opposite him. May stood back, positioned where she could see clearly without being in the way. "Scalpel," Harrison said, holding out his hand without looking up. The first incision was precise, almost artistic in its execution. May had to admit that Harrison's technique was flawless. Every movement economical, confident, born of thousands of hours in the OR. This was why he could get away with his arrogance. When his hands were at work, it was impossible not to respect what they could do. The procedure progressed smoothly through the initial stages. Harrison and Peterson worked together with the wordless coordination that comes from years of collaboration. May watched intently, mentally noting Harrison's techniques, the small refinements to standard procedures that marked his personal style. "Beginning sternotomy," Harrison announced. The bone saw whirred to life, its harsh buzz filling the room as he carefully split Mr. Reynolds' sternum to access the heart. Once the heart was exposed, the team connected the patient to the heart-lung machine. The rhythmic beeping of monitors provided a steady backdrop as they prepared for the critical part of the surgery, replacing the damaged valve. "Heart rate's dropping," the anesthesiologist said suddenly, glancing at the monitor. "Pressure's unstable." A flicker of tension passed through the room. Harrison remained focused, his hands steady. "Increase the dopamine. It's just a response to manipulation. He'll stabilize." But the numbers continued to fall. Mr. Reynolds' heart wasn't responding as expected. He could feel the shift in the room's energy as everyone became more alert, more focused. "BP still dropping," the anesthesiologist reported. 57/30. Harrison's eyes narrowed above his mask. Give him more volume. Peterson, let's move faster here. May stepped slightly closer, her eyes darting between the surgical field and the monitors. Something wasn't right. She had seen this pattern before during her fellowship. It wasn't just normal surgical manipulation, Dr. Harrison, she said quietly. Could it be a vagal response? His history showed unusually pronounced vagal tone during his last catheterization. Harrison didn't look up. If I want your assessment, Dr. Lin, I'll ask for it. May fell silent but continued watching. The patient's pressure stabilized slightly but remained concerning. As Harrison began working on the valve replacement itself, she noticed something in the surgical field, a subtle discoloration of the tissue near where they were working. Dr. Harrison, she tried again, her concern outweighing her hesitation. I'm noticing unusual tissue appearance near the superior aspect of the valve. Could there be calcification that wasn't visible on the imaging? This time Harrison looked up sharply. Dr. Lin, he said, his voice cold. This is why we don't let rookies make decisions. The tissue appearance is perfectly normal for a patient of this age with this condition. He turned to the rest of the team. This is what happens when someone has read too many textbooks and not enough actual patients. Theory versus reality. The OR went silent except for the beeping monitors. Several nurses exchanged uncomfortable glances. May felt heat rising in her face, thankful that her mask hid at least some of her embarrassment. Stick to following orders until you've earned your stripes, Dr. Lin, Harrison continued. Or better yet, observe from the gallery as originally planned. Peterson cleared his throat awkwardly. Richard, maybe we should check. The calcification is minimal and exactly where we expected it. Harrison cut him off. Let's continue. The surgery proceeded, but the atmosphere had changed. May remained where she was, forcing herself to stay focused despite the humiliation burning in her chest. She noticed one of the scrub nurses give her a sympathetic look. Then she saw it. A small but concerning change in the heart's motion as Harrison manipulated the valve area. It was subtle, something many surgeons might miss. But May had spent 6 months during her fellowship with a surgeon who specialized in unusual valve presentations. She recognized the pattern. She had a choice: stay silent and avoid further humiliation, or speak up again and risk Harrison's wrath. The memory of Mr. Reynolds talking about his granddaughter's wedding flashed through her mind. Dr. Harrison, she said, her voice quiet but firm, I believe there may be adhesions on the posterior leaflet that weren't visible on the echo. If that's the case, the standard approach might cause tearing when the new valve is seated. The room went completely still. Harrison's hands paused, hovering over the surgical field. When he looked up at her, his eyes were like ice. Dr. Lin, he said, each word precise and cutting. Perhaps you didn't understand me the first time. Your input is not needed or wanted. This is not a democracy. It's a surgical theater. I have performed this exact procedure hundreds of times. He turned to address the entire room now. This is why having observers in the OR can be problematic. They feel compelled to contribute even when they have nothing of value to add. He looked back at May. If you cannot respect the hierarchy in this room, you can leave. The silence that followed was deafening. May stood frozen, mortified but also increasingly concerned for the patient. She could see that what she'd identified was real. The adhesions were there, and Harrison was missing them. Actually, Peterson said suddenly, leaning in closer to the surgical field, I think I see what Dr. Lin is referring to. He pointed with his instrument. There, posterior leaflet, 3 o'clock position. Harrison's eyes flicked to where Peterson was pointing. For a brief moment, May saw something like uncertainty cross his features. He adjusted the retractor to get a better view. He said after a moment. It wasn't an acknowledgement, but it wasn't a dismissal either. Maybe we should modify the approach, Peterson suggested carefully. Use the technique from the Nakamura study? Harrison was silent for a long moment, his eyes fixed on the surgical field. May held her breath. We'll use a running stitch instead of interrupted, he finally said, as if it had been his idea all along, and approach from the lateral aspect first. It was essentially the modification May had been suggesting. The rest of the procedure continued without incident. The modified approach worked perfectly, and Mr. Reynolds's new valve was seated without any issues. His vitals remained stable as they began closing. May stayed quiet for the remainder of the surgery, but she noticed Peterson glancing at her occasionally with something like respect in his eyes. When they were finishing up, Harrison spoke without looking at her. Doctor, Lynn, you'll handle the post-op notes. It wasn't a request. Yes. Dr. Harrison, she replied professionally. In the scrub room afterward, as May was removing her gown, Peterson approached her. That was good catching those adhesions, he said quietly. Not many would have spotted them. May nodded, unsure how to respond. Thank you for backing me up, Peterson shrugged. It was there. I just didn't see it until you pointed it out. He glanced toward the door to make sure they were alone. Look, Harrison's never going to admit you were right. That's not who he is. But you made the right call. It doesn't feel like much of a victory, May admitted. In surgery, there are no victories, just avoided losses, Peterson said with a small smile. You helped avoid a loss today. That counts for something. By afternoon, May discovered that word of the OR confrontation had spread throughout the hospital. In the cafeteria, she noticed heads turning as she entered, conversations pausing and resuming in hushed tones. A group of residents at a nearby table were clearly discussing what had happened, occasionally glancing in her direction. You're the talk of the hospital, Dr. Kapoor said, sliding her tray onto the table where May sat alone. Not many people stand up to Harrison in his own OR. I wasn't trying to stand up to him, May sighed. I was just concerned about the patient, which is exactly what makes you a good doctor, Kapoor said. But be prepared. Harrison doesn't forget things like this. As if summoned by his name, Harrison appeared at the entrance to the cafeteria with several other senior surgeons. May watched as he leaned in to say something to them, his eyes flicking briefly in her direction. The other doctors laughed, and one patted Harrison on the shoulder. I believe the term he's using is babysitting, Kapoor murmured, following May's gaze. Says instead of working with a colleague, he feels like he's running a daycare. May set down her fork, her appetite suddenly gone. Wonderful. Take it as a compliment, Kapoor advised. You've gotten under his skin. That means he sees you as worth noticing. That's not exactly comforting. It's not meant to be, Kapoor replied with a wry smile. It's medicine. Comfort is for patients, not doctors. As May left the cafeteria, she passed Harrison's table. She held her head high, meeting his gaze briefly as she walked by. His expression was unreadable, but she thought she detected something beyond mere disdain, perhaps a flicker of uncertainty. Good, she thought. Let him wonder. Let him worry that maybe, just maybe, he wasn't always the smartest person in the room. 2 weeks had passed since the Reynolds surgery, and life at Metropolitan General had settled into an uneasy routine for May. The whispers still followed her through the halls, but they had evolved from simple gossip about her confrontation with Harrison to speculation about whose side different staff members were on. It was ridiculous, May thought, that medicine, a field dedicated to healing, could sometimes feel like high school. She was finishing patient rounds when her pager beeped. Emergency consultation in the cardiac ICU. She hurried down the corridor, her mind already shifting into crisis mode. When she pushed through the doors of the ICU, she was surprised to find Harrison already there, standing over a patient's bed with a concerned expression, an unusual sight on his typically confident face. Dr. Lynn, he acknowledged her with a curt nod. Meet Thomas Blackwell, 52, post-op day 5 from a triple bypass. May approached the bed, immediately noting the patient's gray pallor and labored breathing. His bypass was performed here? By me, Harrison replied, a hint of defensiveness in his tone. Textbook procedure, no complications. May scanned the chart handed to her by a nurse. He was readmitted last night with chest pain and shortness of breath. Initially thought to be normal post-surgical recovery pain, Harrison explained, but his condition has deteriorated in the past 3 hours. Oxygen saturation dropping, increased heart rate, fever of 101.3. May looked more closely at the patient. Mr. Blackwell was clearly in distress, his breathing shallow and rapid. A quick check of the monitor showed concerning vital signs. Has he been started on antibiotics? She asked. Harrison nodded. Standard protocol for suspected post-surgical infection, but his symptoms aren't following the typical pattern. The ICU team had gathered around them, 2 nurses, a resident, and Dr. Peterson, who had just arrived. The atmosphere was tense. Everyone could see this patient was in trouble. Let's get another chest X-ray and echocardiogram, Harrison directed. And I want a full blood workup. White count, cultures, the works. He turned to May. What are you thinking? The question surprised her. It was the first time Harrison had directly asked for her opinion without dismissing it in advance. She looked back at the patient, considering. "The timing is concerning," she said carefully. 5 days post-op is when we sometimes see the first signs of infection, but also when certain immune responses to the surgery can manifest. His symptoms could be consistent with several possibilities, infection being the most likely, but we should also consider a pulmonary embolism, early signs of heart failure, or a reaction to one of his medications. Harrison's expression was unreadable as he listened. "Reasonable differential," he said finally. "Let's run with infection as our working diagnosis until the labs come back." The team dispersed to carry out the orders, leaving May and Harrison standing at the bedside. For a moment, there was an almost collegial feeling between them. Two doctors focused on a medical mystery rather than their personal friction. "I've never lost a bypass patient to post-op complications," Harrison said quietly, almost to himself. "Not in 15 years. It was the closest thing to vulnerability May had ever heard from him. 3 hours later, they reconvened in the conference room. The lab results and imaging were displayed on the large screen, and they didn't look good. Mr. Blackwell's condition had worsened despite the interventions. White count is elevated, but not dramatically so, Peterson noted, pointing to the numbers. Cultures are still pending. X-ray shows some fluid in the lungs, but again not extensive enough to explain his level of distress, Harrison said, frowning at the image. Echocardiogram shows good valve function, no obvious leaks or structural issues with the grafts. The room fell silent as everyone studied the results, trying to piece together the puzzle. Mr. Blackwell was sliding downhill, and they didn't know why. "I think we need to consider reopening," Harrison finally said. "There could be bleeding we're not seeing on the scans, or a blockage in one of the grafts." "But his hematocrit is stable," May pointed out. "If he were bleeding internally, we'd see a drop." Harrison's jaw tightened slightly at her contradiction. "Sometimes imaging and labs don't tell the whole story, Dr. Lin. Clinical judgment matters too." "I agree," May said, choosing her words carefully, "which is why I'm concerned that reopening might put additional stress on a patient who's already struggling. If we're missing something fundamental about his condition, surgery could make it worse." The tension in the room ratcheted up. The other doctors and nurses glanced between them, sensing another confrontation brewing. Harrison straightened, his full height imposing as he looked down at May. "And what, exactly, do you think we're missing, Dr. Lin? Please enlighten us with your vast experience." The sarcasm was back, the momentary collegiality gone. May took a deep breath, reminding herself that this was about the patient, not her pride. "During my fellowship, I worked with a patient who presented similarly after bypass surgery," she began. "It turned out he had a rare reaction to the combination of his post-surgical medications and a genetic factor that wasn't on his chart. His body was essentially rejecting the treatment, not the surgery itself." "A rare reaction," Harrison repeated flatly. "How convenient. And unverifiable." "It's documented," May insisted. "There was a paper published in the Journal of Cardiothoracic Medicine last year about similar cases." "I can pull it up?" "Dr. Lin," Harrison interrupted. "While I appreciate your enthusiasm for obscure case studies, we're dealing with a real patient who needs real solutions, not academic theories. Mr. Blackwell has a textbook presentation of either a developing infection or a surgical complication. We will treat accordingly." He turned to address the entire team. "Prepare for surgery in 1 hour. We'll do an exploratory procedure to check the grafts and look for any hidden bleeding or infection sites." The team nodded and began to disperse. May stood her ground. "Dr. Harrison, I really think we should at least check his medication interactions and run a quick genetic panel before putting him through another surgery." If you're right," Harrison cut her off. "You can write a paper about it. But right now my patient is dying, and I'm going to save him the way I've saved thousands of others with proven medical intervention, not guesswork." His voice had risen slightly, drawing attention from staff outside the conference room. He seemed to notice and lowered his tone. "I've been saving lives since you were in grade school, Dr. Lin. Your input isn't needed here." The dismissal was absolute. Harrison walked out, leaving May standing alone in the conference room, frustrated and increasingly worried about Mr. Blackwell. She found herself wandering to the hospital's medical library after her shift ended, even though she should have been heading home after the long day. Something about Mr. Blackwell's case tugged at her memory. A pattern she'd seen before but couldn't quite place. The library was quiet at that hour, just a few residents studying in corners. May logged into one of the computers and began searching medical journals, looking for the paper she'd mentioned to Harrison. When she found it, she printed it out, highlighting key sections that matched Mr. Blackwell's presentation. She was so absorbed that she didn't notice Dr. Kapoor approaching until the older woman spoke. "I heard about the Blackwell case," Kapoor said, setting down her coffee. "And about round 2 with Harrison," May sighed. "News travels fast. It's a hospital. Gossip moves faster than bacteria here." Kapoor glanced at the papers spread across the desk. "What are you looking for?" "Something that might save Mr. Blackwell," May replied, pushing the journal article toward her. "Look at this case series. 5 patients, all with similar presentations after cardiac surgery, all with symptoms that mimicked infection or surgical complications." Kapoor skimmed the paper, her expression thoughtful. "Interesting. Did you show this to Harrison?" "I tried to tell him about it. He wasn't interested." May ran a hand through her hair in frustration. "They're prepping Mr. Blackwell for surgery right now. If I'm right, it won't help. It might even make things worse." "So what are you going to do about it?" Kapoor asked, studying her intently. "What can I do?" Harrison made his decision. "He's the attending surgeon." "True," Kapoor said, leaning back in her chair. "But you're also an attending physician with privileges at this hospital. You have options." May looked up sharply. "What are you suggesting?" "I'm not suggesting anything," Kapoor replied with a small shrug. "I'm just reminding you that medicine isn't a dictatorship even if Harrison acts like it is. If you genuinely believe a patient is at risk, there are channels." She stood to leave, then paused. "Whatever you decide, be sure it's for the right reasons. Ask yourself if you're doing it for the patient or to prove Harrison wrong. Only one of those is worth the fallout that will come." After Kapoor left, May sat staring at the research papers, her mind racing. The parallels between the case studies and Mr. Blackwell were too strong to ignore. His symptoms, the timing, the lack of clear findings on imaging, it all fit the pattern of the rare reaction described in the journal. She checked the time. The surgery would be starting soon. If she was going to act, it had to be now. Taking a deep breath, May gathered the papers and headed for the chief of medicine's office. This wasn't about Harrison anymore or about her wounded pride. This was about a patient who might die if someone didn't speak up. As she walked, her pager beeped with an urgent message. "Blackwell coding. All available cardiac staff to ICU stat." May broke into a run, her heart pounding. She was too late. The crisis had accelerated, and now Mr. Blackwell's life hung by a thread. Whether Harrison would listen to her now, with their patient crashing before surgery even began, remained to be seen. May sprinted through the hospital corridors, the research papers clutched in her hand. As she neared the ICU, she could hear the controlled chaos of a code blue, urgent voices calling out orders, the clatter of equipment, the steady tone of heart monitors showing no rhythm. She burst through the doors to find the team surrounding Mr. Blackwell's bed. Harrison was already there, barking orders as a nurse performed chest compressions. The scene was intense but disciplined, each person knowing their role in this life-or-death dance. What happened? May asked a nearby resident. "Sudden drop in pressure, then arrest," the young doctor replied. "No warning signs beyond what we already knew." Harrison glanced up, noticing her arrival. "Lynn, get in here. We need another pair of hands." May joined the circle, setting her papers aside. For the next 20 minutes, they worked in unison, their personal conflicts temporarily forgotten in the shared mission to save a life. When they finally stabilized Mr. Blackwell, the relief in the room was palpable, though everyone knew it was likely temporary. "He won't survive another event like that," Harrison said grimly, studying the monitors. "We need to get him to surgery now." "Dr. Harrison," May said, retrieving her papers, "before we rush into surgery, please look at this." She held out the journal article. Mr. Blackwell's symptoms match this case series exactly. It's a rare reaction to the combination of beta blockers and the specific antibiotic he's on, exacerbated by a genetic factor. Harrison's expression hardened. "We don't have time for this." "We don't have time not to consider it," May insisted. "If I'm right, surgery could kill him. We need to change his medications and run a quick genetic test to confirm." Based on a single journal article? Harrison's voice was incredulous. "You want me to delay life-saving surgery for a theory?" It's not just theory. Look at his labs, May pointed to the chart. The pattern is consistent. His white count isn't high enough for a major infection. His hematocrit is stable, ruling out significant bleeding. His cardiac enzymes don't suggest a new infarct. What's killing him isn't surgical, it's biochemical. The ICU had gone quiet, all eyes on the two doctors. Harrison looked from May to the paper, then to the patient. Even if you're right, he said finally, it would take hours to get genetic testing results. He doesn't have hours. Then let's at least change his medications as a precaution, May urged. If I'm wrong, we've lost nothing. If I'm right, it might buy us the time we need. Harrison shook his head. Too risky to change course now. We go with what we know works, surgical intervention. He turned to the team. Prep for OR3. I want him on the table in 20 minutes. As the team moved to follow his orders, Harrison pulled May aside. I understand your concern, he said, his voice lower. But this is my patient, my call. Your job right now is to support the decision, not challenge it. My job is to advocate for the best care for our patient, May replied quietly. Even when it's difficult. Harrison's pager beeped. He checked it and frowned. I have to take this, it's the hospital board. The OR team knows what to do. I'll meet them there in 10 minutes. He fixed May with a stern look. Don't interfere. After he left, May stood by Mr. Blackwell's bed, watching his numbers slowly deteriorate again despite their interventions. The OR team was gathering equipment, preparing for transport. Time was running out. She made a decision. I need to speak with Dr. Winslow, she told the charge nurse, referring to the chief of medicine. He's in a meeting with the board. That's probably why Harrison was called away, the nurse replied. May felt a surge of frustration. The two people who could authorize a change in treatment were both unavailable, and Mr. Blackwell was slipping away. She pulled out her phone and dialed a number. Dr. Tanaka? It's Mei Lin from Metropolitan. I was your fellow last year. She quickly explained the situation. Does this sound like the Hoffman case to you? Dr. Tanaka was silent for a moment. It does, he finally said. Almost identical. Have you run the genetic panel? No time, May replied. The patient is crashing and they want to rush him to surgery. Surgery is the worst thing you could do right now if it's the same reaction, Dr. Tanaka said firmly. You need to change his medication protocol immediately. The attending won't approve it, May said, watching the monitors. Then you have a choice to make. Dr. Tanaka's voice was grave. I can't tell you what to do from across the country, but I will say this. In the Hoffman case, we almost lost the patient because we waited too long to recognize the pattern. Your judgment has always been solid, May. Trust it. After hanging up, May stared at Mr. Blackwell's gray face. The transport team was almost ready to move him. Dr. Lin, one of the nurses, said gently, We need to take him now. May looked around at the staff, people she'd worked with for months, who respected Harrison and followed his orders without question. What she was considering could end her career if she was wrong. But if she was right and did nothing, Mr. Blackwell would die. Hold transport, she said, her voice surprisingly steady. I'm implementing an emergency protocol change. The room went still. Dr. Harrison ordered surgery, the transport coordinator reminded her. I understand, May said. But as an attending physician, I'm exercising my clinical judgment that transport would endanger this patient's life. She turned to the ICU pharmacist. I need to change his medication protocol immediately. Discontinue the current antibiotic and beta blocker. Start him on this alternative regimen. She quickly wrote out the orders, her handwriting neat despite the pressure. The pharmacist hesitated, looking at the other staff members. We could call Dr. Harrison again, someone suggested. There's no time, May said, pointing to the monitors. Look at his numbers. He won't survive the trip to the OR, let alone surgery. The charge nurse stepped forward, studied the orders, then looked at May for a long moment. Whatever she saw in the young doctor's face must have convinced her. Do it, she told the pharmacist. I'll document the change as an emergency intervention. The next 30 minutes were the longest of May's life. As the new medications were administered, she stayed by Mr. Blackwell's side, watching for any sign of improvement or deterioration, aware that every person in the ICU was watching her. She'd put everything on the line, her reputation, her career, perhaps even her license if this went badly wrong. Send his blood for the genetic panel, she instructed a lab tech. Mark it urgent. We need confirmation of factor V mutation. Dr. Lin, the charge nurse called softly. Look. May turned to the monitors and felt a surge of hope. Mr. Blackwell's oxygen saturé. Keep monitoring. This is just the beginning. If I'm right, we should see continued improvement over the next hour. Word must have traveled fast because Dr. Peterson appeared in the ICU, slightly out of breath. What's happening? He asked, taking in the scene. I heard Blackwell coded and then something about a medication change. May explained her reasoning, showing him the research and the early signs of improvement. Peterson listened carefully, then checked the patient himself. Interesting, he said finally. Very interesting. And gutsy? Stupid maybe, May admitted. Harrison is going to be furious. Oh, without question, Peterson agreed. But if you've just saved this man's life when surgery would have killed him, that's going to be a difficult argument to counter. An hour later, Mr. Blackwell was showing clear signs of improvement. His color was better, his vitals stabilizing, his oxygen requirements decreasing. The genetic panel would take hours to come back, but his response to the medication change was already confirming May's diagnosis. She was updating his chart when she heard the ICU doors slam open. Harrison stood there, his face a mask of controlled fury as he took in the scene. Mr. Blackwell, still in the ICU, clearly improving. The nursing staff moving with renewed purpose. The surgery that never happened. Who countermanded my orders? He demanded, though his eyes were fixed on May. When no one immediately answered, he strode forward. I said, who made the decision to cancel surgery? May stood up straight. I did. Based on what authority? His voice was deadly quiet. Based on my clinical judgment as an attending physician that the patient was experiencing a rare medication reaction that surgery would have worsened, May replied, handing him the chart. His improvement under the new protocol confirms the diagnosis. Harrison scanned the chart, his expression unreadable. The entire ICU seemed to hold its breath. You took an extraordinary risk, Dr. Lin, he finally said. If you were wrong, but she wasn't, Dr. Peterson interrupted, stepping forward. The patient is improving rapidly. The lab just called. The genetic panel is preliminary positive for the factor V mutation she suspected. Harrison looked from Peterson to May, then to Mr. Blackwell, whose color was visibly better than an hour ago. You went over my head, Harrison said to May, his voice still tight with anger. You violated the chain of command and risked a patient's life on a hunch. Not a hunch, May corrected gently. Evidence-based medicine applied to a case that didn't fit the usual pattern. Harrison fell silent, studying Mr. Blackwell's monitors. The improvement was undeniable. I need to see the complete genetic results and the research you based this on, he said finally, and this incident will be reviewed by the ethics committee. I understand, May said, relieved that at least he wasn't calling for her immediate dismissal. As Harrison turned to leave, he paused. The patient, he said without looking back, is responding well to your treatment. Continue with the current protocol. It was as close to an acknowledgement as she was likely to get. After he left, Dr. Peterson squeezed her shoulder. You did good, he said quietly. Really good. But you might want to update your resume just in case. May smiled tiredly. Worth it, she said, looking at Mr. Blackwell, whose eyes were now open, watching them curiously. Completely worth it. The following days passed in a strange limbo for May. Mr. Blackwell continued to improve, his recovery now deemed remarkable by the same staff who had been preparing for the worst. The genetic test results had come back fully positive for the factor V mutation, confirming May's diagnosis beyond any doubt. By all medical measures, she had saved his life when surgery would have likely ended it. Yet the professional fallout remained uncertain. Harrison had been noticeably absent from the ICU since their confrontation, leaving the patient's care to May and the rest of the team. The hospital grapevine buzzed with rumors. Harrison was pushing for disciplinary action. The ethics committee was split. The chief of medicine was impressed by May's judgment, but concerned about her defiance of the established hierarchy. May tried to focus on her work and ignore the whispers, but it wasn't easy. Every time her pager beeped, she half expected to be summoned to hear her fate. You look exhausted, Dr. Kapoor commented, finding May in the doctor's lounge staring into a cup of cold coffee. When did you last sleep properly? May shrugged. What day is it? That's what I thought. Kapoor sat down across from her. The Blackwell case is closed, you know. He's being discharged tomorrow. Full recovery expected. I know. I signed his release papers this morning. Then why do you look like you're attending your own funeral? May sighed. Because my career might be. Harrison hasn't spoken to me in 3 days, but I hear he's been in meetings with administration. I basically hijacked his patient and contradicted his treatment plan. Even though I was right, that's not how things work in hospitals. True, Kapoor agreed. Though being right does count for something. She hesitated. For what it's worth, I think you showed extraordinary clinical judgment. Many doctors with twice your experience wouldn't have made that connection, or had the courage to act on it. Thanks, May said with a small smile. I just wish her pager interrupted her. The message was brief. Dr. Winslow's office now. May's stomach dropped. That's it. The chief of medicine wants to see me. Kapoor squeezed her arm. Remember, whatever happens, you saved a life. Hold on to that. The walk to Dr. Winslow's office felt endless. May rehearsed what she would say, how she would defend her actions without seeming insubordinate. As she approached, she was surprised to see Harrison emerging from the office. He paused when he saw her, his expression unreadable. Dr. Lin, he acknowledged with a nod. Dr. Harrison, she replied, unsure what else to say. He seemed about to walk past her, then stopped. Winslow's waiting for you, he said, then added almost reluctantly. Good luck. Before she could respond, he was gone, leaving her confused by the unexpected civility. Dr. Winslow was reviewing documents when she entered his office. A tall man in his 60s with a calm demeanor, he had a reputation for fairness tempered with strict adherence to hospital protocols. Dr. Lin, please sit down, he said, gesturing to the chair across from his desk. May sat, hands folded in her lap to hide their slight trembling. I've been reviewing the Blackwell case, Winslow began, including the timeline of events, your research basis for the intervention, and the outcome. He looked at her directly. It's quite a remarkable story. Thank you, sir, May said cautiously. It's also a serious breach of our established chain of command, he continued. Dr. Harrison was the attending surgeon of record. The proper procedure would have been to continue attempting to reach me or wait for his return before making such a significant change in treatment. May nodded. I understand that, sir. But Mr. Blackwell was deteriorating rapidly. I genuinely believe that waiting would have cost him his life. Winslow studied her for a moment. And that belief was based on solid medical reasoning and prior case knowledge, not on a desire to prove Dr. Harrison wrong. Absolutely not, May said firmly. This was never about Dr. Harrison, it was about the patient. Winslow leaned back in his chair. That's essentially what Dr. Harrison just told me. May blinked in surprise. Dr. Harrison defended me? In his own way, Winslow said with a slight smile. He acknowledged that while your methods were unorthodox and against protocol, your medical judgment was sound and ultimately correct. He shuffled some papers on his desk. He also pointed out that the research you cited was quite recent and not yet widely incorporated into standard protocols, which partially explains why he wasn't familiar with the reaction pattern you identified. May was speechless. The last thing she had expected was for Harrison to speak in her favor. That said, Winslow continued, we still have the issue of protocol violation to address. The hospital can't function if doctors routinely override each other's treatment plans, even with the best intentions. I understand, May said, her heart sinking. So here's what we've decided, Winslow said. There will be a formal note in your file about this incident. However, it will be accompanied by a commendation for exceptional clinical judgment resulting in a life-saving intervention. He fixed her with a serious look, and you will work with the education committee to develop a training module on this specific medication interaction for all cardiac staff, to ensure that this particular situation doesn't arise again. May stared at him. I'm not being disciplined? The note in your file is the disciplinary action, Winslow explained. But in medicine, we try to learn from exceptional cases, not just punish the exceptions to protocol. He stood, indicating the meeting was concluding. Dr. Harrison suggested the training module, by the way. He thought your knowledge on this particular interaction should be shared with the department. Still processing this unexpected outcome, May thanked Dr. Winslow and left his office. The hallway was quiet, most staff already gone for the day. She decided to make one last visit to Mr. Blackwell before heading home. She found him sitting up in bed, color restored to his face, looking at pictures on his phone with his wife. "Dr. Lin," he greeted her warmly. "My guardian angel," May smiled. "How are you feeling, Mr. Blackwell?" "Like I'm ready to dance at my granddaughter's wedding," he replied with a grin. "The nurses told me what happened, that you fought to change my treatment when others wanted surgery." "It was a team effort," May said diplomatically. Mrs. Blackwell shook her head. "That's not how they tell it. They say you put your job on the line to save my husband." She reached out and squeezed May's hand. "Thank you." Embarrassed by their gratitude, May checked his chart one last time and wished them a good night. As she left the room, she was startled to find Harrison standing in the hallway, apparently waiting for her. "Dr. Harrison," she acknowledged. "Unsure what to expect, walk with me," he said, starting down the corridor without waiting for her response. They walked in silence for a moment before Harrison spoke again. "Winslow told you about our meeting?" "Yes," May replied. "Thank you for supporting the training module idea." Harrison nodded. "It makes sense. If one doctor missed this interaction pattern, others could too." He paused by a window overlooking the hospital grounds. "I've been reviewing your notes and the research paper you cited." The pattern recognition was impressive. Coming from Harrison, it was high praise indeed. "I had an advantage," May admitted. "My fellowship mentor had handled a similar case. Without that exposure, I might have missed it too." "Perhaps," Harrison said. "But you didn't just recognize the pattern. You acted on it decisively when time was critical." He turned to face her directly. "That's not something that can be taught." May was surprised by the genuine respect in his voice. "I've been head of this department for 15 years, Harrison continued. "In that time, I've worked with many young doctors. Most of them are technically competent. Some are even exceptional surgeons, but very few have the combination of knowledge, intuition, and courage that you demonstrated with Blackwell." He looked away, seeming almost uncomfortable with what he was about to say. "I've been reviewing your notes on other cases too. Your assessments are consistently thorough. Your diagnoses sound. Your technical skills in the OR, from what Peterson tells me, are excellent." "Thank you," May said, genuinely touched by the unexpected praise. "Don't thank me yet," Harrison replied with a hint of his usual dryness. "Because I'm also putting you on the Thompson case, the complex valve repair. I want you to lead with me assisting." May stared at him. The Thompson case was one of the most challenging surgeries currently scheduled, a chance to demonstrate skill that was rarely given to doctors with her limited experience. "Are you sure?" she asked. "I wouldn't offer if I wasn't sure," Harrison said firmly. "You've earned it." He started walking again. "We'll review the approach together tomorrow. I have some techniques that might be useful for this particular anatomy." As they reached the elevator, Harrison pressed the call button, then turned to her one last time. "I missed something critical with Blackwell that you caught," he said quietly. "The patient would have died under my care alone." He met her eyes directly. "I don't make the same mistake twice, Dr. Lin, especially when that mistake is underestimating a colleague." The elevator doors opened and Harrison stepped inside. 8 a.m. tomorrow for the Thompson review," he said as the doors began to close. "Don't be late." May stood there for a moment after he'd gone, a slow smile spreading across her face. It wasn't friendship, and Harrison would likely never be an easy person to work with. But it was something perhaps more valuable in their profession: genuine respect. As she finally headed home, May felt a weight lift from her shoulders. She had come to Metropolitan to learn and grow as a doctor, to save lives and make a difference. Today, for the first time, she truly felt like she belonged.